Colleagues, good evening. Welcome to this webinar organized by EuReCa-M, European Renal and Cardiovascular Medicine Working Group of ERA, European Renal Association. I'm Olga Balafa. I'm a nephrologist from Greece. I'm a member of the EuReCa-M board, and I'm hosting this webinar today. The topic of our webinar is sleeping breathing disorders in CKD, risks and remedies. Sleeping disorders is a rather underestimated clinical issue in everyday clinical practice, and most colleagues are not familiar with the diagnosis. I'm really honored, proud, and delighted to introduce you our speaker and panelists today. All of them are distinguished nephrologists. Our speaker today is Professor Francesca Mallamaci. Professor Mallamaci is the chairwoman of EuReCa-M board. She is the chief of the nephrology department in Ospedale Riunite in Reggio Calabria, Italy. She's an outstanding nephrologist in European renal community with huge clinical experience, important numerous publications and presentations. Part of her research interests involves sleeping and breathing disorders in CKD, and today she's going to share part of that expertise with us. Mrs. Mallamaci is going to start the lecture, and afterwards I'm going to call our panelists to comment. Both our panelists are also eminent nephrologists, experts on CKD and CVD mortality, with huge clinical training, educational and research experience. Our first panelist is Professor Charles Ferro. He is the vice chair of EuReCa-M board. He is the consultant nephrologist in renal medicine department in Birmingham, United Kingdom. And our second panelist is Professor Alberto Ortiz. He was a EuReCa-M member. Now he's ERA Council member and the editor-in-chief of CKD Journal. He is the chief of nephrology and professor of medicine in University Autónoma of Madrid, Spain. At the end of this webinar, we are going to discuss your questions. So I'm urging you to write down your questions in question and answer section. I hope we are going to address all of your questions at the end of the seminar. At this point, I would like to inform you that by participating live in this event, you will also earn 1 European CME credit exclusive benefit for ERA members. It was rather a long introduction. We're ready to start now. Professor Mallamaci, please do start.
Okay, thank you, Olga, for your presentation. And I'm going now to speak about the sleep apnea in CKD. I have no conflict of interest. Disturbed sleep is a risk-generating situation if breathing is interrupted, apnea, or if also when the depth of breathing is halved, is hypopnea. Sleep apnea can be central when there is no neural drive to respiratory cage, or peripheral, that is better known as obstructive. Sleep apnea is a concerning problem at the population level. And the first paper, which was published about this topic, was published in the New England Journal of Medicine. And it was a study in middle-aged men in the general population. In this paper was shown that moderate to severe sleep apnea is a common problem in middle-aged men, where the prevalence is 12%. And is more frequent in men than in women, where the prevalence was found to be 5%. But what is important to know about sleep apnea, that it increases the risk of stroke and death, as you can appreciate in these curves, where patients with sleep apnea had a higher risk of stroke and death in comparison to controls. and sleep apnea risk was independent of other risk factors, including hypertension. But how sleep apnea generates a high cardiovascular risk? This is a graph of sympathetic activity which was recorded at the peroneal nerve. And when the respiratory airflow falls, the oxygen when the respiratory airflow stops, the oxygen saturation falls, and the sympathetic bars increase. The result is an increase of arterial pressure, and the result of all these alterations is hypertension, particularly nocturnal hypertension, left ventricular hypertrophy, and arrhythmias. Sleep apnea is even more frequent in CKD patients than in the general population. And the reason why is so, we all know that in CKD there is a sodium retention. And peripherally, the sodium retention is evident with ankle edema, for example. But sodium retention is not only a peripheral phenomenon, it's a systemic phenomenon. And this is very well shown in this resonance in the head of a CKD patient in a supine position during the sleeping hours. You can appreciate here the pharynx and the uvula. We know that these are very narrow spaces, anatomical spaces, but they become even narrower when there is an increase in fluids. And this narrowing brings to sleep apnea, hypoxemia, snoring. And the sleep apnea snoring is a potent sympathetic activation in the central nervous system. Sympathetic activation is maintained well beyond the night hours and extends to the daytime hours, generating a powerful vasoconstrictive pro-hypertensive condition. In CKD, salt intake and sleep apnea are dominant factors in resistant hypertension. The issue is even more relevant in end-stage kidney disease, where volume expansion, as we all know, is exceedingly common. But from an epidemiological point of view, we know that the ideal approach to study the problem is studying the relationship between GFR, renal function, and sleep apnea in population-based studies. And this is a study by Panellists where renal function and sleep apnea was assessed in older men. This was a cohort of more than 2,600 men. They were 65 years old, and they were enrolled in the Mr. OS sleep study. Creatinine was measured 3 years before the study. As you can appreciate here from this graph, individuals in the first quartile, that is the stage 3 CKD, have an identical number of apneic episodes as compared with those having higher GFR levels. Overall, moderate stage 3 CKD does not seem to underlie a higher risk for sleep apnea. But in studies where the analysis was focused in patients with later stages of CKD, that is stage 3B and 4, the frequency of sleep apnea was quite high. This is a small study, but it was performed very well, and the clearance of these patients was less than 40 milliliters per minute. In these patients, those with a medium severity of sleep apnea, that is apnea-hypopnea index, that is the way to measure sleep apnea, was 15 hours, were 31%, while those patients with severe sleep apnea, more than 30 of AHI, was about 6%. And as you can appreciate here, the severity of respiratory disturbances in CKD increased as CKD approached the end stage phase. Now we have been speaking about the prevalence and the sleep apnea in CKD patients. But what is the prevalence and the severity of the phenomenon of sleep apnea in dialysis patients? Here, the range of prevalence is quite wide. In fact, it's 15% in unselected dialysis population, but it climbs up to 75% in dialysis population selected because of symptoms. So sleep apnea is common in end-stage renal disease patients, a condition at extremely high risk for cardiovascular death. And this was documented in a paper published in JSON many years ago by our group, where we found that the oxygen saturation patients with an oxygen saturation below higher than 95 and those below 95 had a different risk for fatal and non-fatal cardiovascular events. Indeed, those patients with a low saturation of oxygen, so with sleep apnea, had a worse survival. And these findings were later on in 2010 confirmed by a study published in JSON by another group. Then sleep apnea is associated with evidence of cardiovascular damage and predicts a high death risk in end-stage renal disease patients. But we have another category of CKD patients, a very special category of CKD patients, and they are renal transplant patients. We know that renal transplant patients have a cardiovascular death risk that is much, much higher than that in the general coeval population. And as you can see here, the relative risk of cardiovascular death was 2 times higher in renal transplant patients, is the yellow line, than in the general population. In other words, the risk was 230% higher in renal transplant patients than in the general population. The question point is, sleep apnea still contribute to this high risk in renal transplant patients? Because we know that renal transplantation is in theory the ideal way of correcting sleep apnea, because a restored renal function should abrogate the uremic toxicity. We studied the problem in population in renal transplant patients and in the general population in Italy. And as you can see, the prevalence of sleep apnea in measured, assessed by the apnea-hypopnea episodes hour was very similar in the general population, males and females, and in renal transplant patients. The fact that the prevalence of sleep apnea in renal transplant patients did not differ from that in the general population in the face of the high prevalence of this disturbance in dialysis patients supports the contention that the renal transplantation reverses, at least in the early stages, sleep apnea. And the beneficial effect of renal transplantation on sleep apnea was confirmed by the fact that when patients return to dialysis because of graft failure, in 3 of these patients, it was associated with a worsening of the apnea-hypopnea index and of oxygen desaturation episodes, as you can appreciate in these 2 graphs. So, renal transplantation improves sleep apnea, but we know very little about the longitudinal long-term evolution of sleep apnea after kidney grafting, as well as the effect of sleep apnea worsening on 24 hours ABPM that we recently investigated. We performed more than 400 polysonographic recordings over 3 years in 221 renal transplant patients. And we performed at the same time 24 hours ABPM. This is a paper we published 1 year ago, where we looked at the long-term changes in sleep disorder breathing in renal transplant patients. And as you can see here, at baseline, the value of apnea-hypopnea index was about 2. But in the second and the third visit, in the follow-up of these patients, the apnea-hypopnea index worsened. So sleep apnea worsened. By a statistical approach, that is the generalized estimating equations method, we documented that only body mass index, age, and male gender significantly associated with the increase in apnea-hypopnea index over time. And the conclusion of this study, the main message was that overweight and obesity, that is a potentially modifiable risk factor, is an important factor underlying the risk of sleep apnea in this population, the renal transplant population. In another study, we looked also at the relationship between the severity of sleep apnea and hypertension in 221 kidney transplant patients. Mean age was 47, and the males were 70%. At baseline, you can appreciate here in this graph that blood pressure increased with the severity of sleep apnea, with the increase of apnea-hypopnea index. Baseline 24 hours blood pressure, systolic blood pressure, but also nighttime systolic blood pressure had the same behavior. So at baseline, there was a stepwise increase of 24 hours and nighttime systolic blood pressure in transplant patients. During the follow-up, 139 patients repeated at least 2 times simultaneous polysonographic studies and ABPM, 24-hour ABPM recordings. In 99 patients, there wasn't any worsening of sleep apnea, while in the remaining 40, sleep apnea worsened during this time. But now we focus in those patients without worsening in sleep apnea. And as you can appreciate here, blood pressure was stable at baseline and in the follow-up, in the last visit, in the last, it's either the systolic blood pressure 24 hours and the nighttime systolic blood pressure. All these ABPM components remained stable over time. But what happened in those patients who had a worsening in sleep apnea in the follow-up? You can see here very clearly that they had an increase in blood pressure, in 24 hours systolic blood pressure, and nighttime systolic blood pressure. Then a further analysis was performed by the linear mixed models adjusted for potential confounders such as age, gender, body mass index, glomerular filtration rate, and diabetes. This analysis confirmed an independent association between the worsening in sleep apnea and the simultaneous increase in 24-hour and nighttime systolic blood pressure in renal transplant patients. Another group I think from Spain, performed a very interesting study about the impact of kidney transplantation on sleep apnea severity, and this was a prospective polysonographic study. 196 patients were studied, those on the waiting list, and were enrolled and screened for sleep apnea using home nocturnal polysonography to measure the apnea-hypopnea index, and these same patients performed the bioimpedance to assess body composition. Of the 88 participants with sleep apnea, 42 were reassessed 6 months post-transplantation and were compared with 27 control patients. As you can see here, the sleep apnea, as we have shown in our study, improved after transplantation. And also, this improvement was in a way associated with improvement in the control of fluid, and body water was reduced after transplantation. And the relationship between sleep apnea, that is the apnea-hypopnea index, the delta, and the delta fluid overload had a very nice relationship. And the improvement, we can say that the improvement in the severity of sleep apnea after kidney transplantation, with a concomitant reduction in body water and a positive correlation between the reduction of fluid overload and the improvement in apnea-hypopnea index with kidney transplantation supports the hypothesis that fluid overload plays a role in the pathogenesis of sleep apnea in end-stage renal disease patients. But so far, we spoke about risk in sleep apnea. What about remedies? We know that reduction of fluid overload could be an important treatment, so controlling body water. But what about devices for sleep apnea? And what about the continuous positive airway pressure? We know that nowadays there are a lot of such devices. Some of them are complex, they are not well tolerated by patients, but now there are small devices for CPAP that are much better tolerated by patients. You can see here in the last image one of these. But to date, there are no trials evaluating the effect of sleep apnea treatment in patients with CKD. There is just one cohort study on kidney function, and the purpose of this study was to test the feasibility and the efficacy of CPAP therapy in CKD patients with sleep apnea. This was published in Medicine, and the effect of continuous positive airway pressure therapy for obstructive sleep apnea was studied related to progression of chronic kidney disease. This study was done in 269 patients, stages 3-4 CKD, but this was a non-randomized cohort study. 148 were without sleep apnea, 79 had mild sleep apnea, and 42 moderate to severe sleep apnea. In the same patients, 52 patients with sleep apnea had received the CPAP treatment for 12 months. As you can see, patients with mild sleep apnea who didn't receive the CPAP treatment had a higher decline, of GFR in comparison to those patients who received the CPAP. And this effect on GFR was even more evident in patients with moderate to severe sleep apnea. This study in CKD patients with sleep apnea shows that the CPAP therapy has a beneficial effect on CKD progression, especially in those with moderate to severe sleep apnea. But now we need a trial. And this protocol was published in the BMJ. The purpose was to test the feasibility and the efficacy of the CPAP therapy in 60 patients with stage 3-4 CKD and with sleep apnea. The study design is a randomized, controlled, non-blinded, parallel clinical trial in which patients with established CKD are screened for sleep apnea. One arm is randomized to medical therapy and CPAP, and the other arm is randomized to conventional medical therapy, and this is the control group. The duration, the follow-up duration is 1 year, and the primary outcome would be the change in estimated glomerular filtration rate. The secondary outcome is to determine the efficacy of a CPAP treatment on proteinuria, sleep-related symptoms, and quality of life. That's the most important point, in my opinion. And the protocol, in the protocol, there is also the assessment at 3, 6, 9, and 12 months after randomization of all parameters of sleep, of the parameters I already presented. Which are the strengths and the limitations of this study? This is the first randomized controlled trial to evaluate the impact of continuous positive airway pressure on renal function in patients with stage 3 or 4 chronic kidney disease. Patients will be recruited from nephrology clinics, which make the findings relevant to this patient population and their healthcare providers. Although the primary outcome and the secondary outcome are not absolute, such as mortality or need for dialysis, they reflect a change in kidney function that could be used in clinical practice. This is a single-center study which may limit its generalizability. But the study is still on. So in conclusion, sleep apnea is an important cardiovascular risk factor in the general population, in CKD and dialysis patients. The prevalence of sleep apnea is lower in the early phases of renal transplantation compared to CKD and dialysis patients, and it is comparable to that of the coeval general population. Sleep apnea, which is a potentially modifiable risk factor, is the main determinant of nocturnal hypertension in renal transplant patients. Even though renal transplantation produces an early improvement in sleep apnea, this treatment does not stabilize the disturbance, which gradually reemerges over longitudinal observations, and the rise in body mass index appears to be of paramount importance. Clinical trials about treatment of sleep apnea and outcomes in CKD patients are strongly needed, and there is one which is going on, but we will have the results maybe next year. Thank you very much for your attention.
Can I ask you, start off with the questions? That's okay with Alberto as well. Francesca, we've got here a condition that's in dialysis patients is very common, as you've shown us.
No, I couldn't hear.
Sorry, the condition is very common in dialysis patients.
The condition?
The condition of sleep apnea.
The sleep apnea, yes.
It's very common in dialysis patients.
Yes, yeah.
Particularly if they've got symptoms.
Yes.
It's fairly easy and straightforward to test for it if they've got that condition. And it's very easy, well, reasonably easy to treat patients. Do you think there's enough there to already justify screening dialysis patients for this condition and treating them? Or do you think we need to wait for the outcomes of hard endpoint studies, which will be thousands of patients and maybe never happen?
Yeah, thank you. Thank you, Charlie. This is a very important question, I think, because it's simple to make a diagnosis of sleep apnea in our patients, just asking a simple question: do you snore? Because people who snore, they very often have sleep apnea, an important degree of sleep apnea. So I think it's important to screen patients for sleep apnea. First of all, just asking if they snore.
Should we then test, or should we just go ahead and treat them, do you think?
I can't hear you properly, Charlie, sorry.
If they snore, do you think we should go automatically and test them, or do you think if they snore, it's 75% that they guaranteed that
Yes.
they've got sleep apnea. Should we just go and treat them?
This is true, but if a dialysis patient snores and he or she has other risk factors, obesity and so on, so we can guess that they have a long period of apnea. So I think that we should screen them and make polysonography for them.
Or then treat them.
Devices that we use to diagnose the sleep apnea.
My second question, Francesca, is you're one of the lead investigators in the LUST trial, which I'll remind the audience is about using lung ultrasound scan to optimally manage fluid in dialysis patients. Is there any data going to be coming from the LUST trial about sleep apnea and whether it improves with fluid optimization?
Well, in that trial, I think, if I understood your question, Charlie, in the study about lung ultrasound, we didn't have the sleep apnea assessment. Okay. So we don't have this information. But people who did it, not with lung ultrasound, but people who assessed the water by the bioimpedance assessment measurement, they noted that the fluid overload is strictly related to sleep apnea. So the more the volume, the more the sleep apnea. So this is very important. Just controlling the volume, we can decrease the severity of sleep apnea.
That's interesting. So when I do my ward round in my dialysis unit next week, I'll ask people if they snore, and if they snore, I'll turn that fluid off.
Charlie, can I ask you to increase the volume of your, because I can't hear you properly. I don't know my phone.
Can you hear me now?
Okay, Olga.
I'm back. Okay. Professor Charles Ferro, do you want to comment?
Yeah.
Do you have any other questions? I can hear you now. I can hear you pretty well.
Francesca, so I was just making the point, when I do my ward round in my dialysis unit next week, if people snore, when I ask people, do they snore, shall I automatically reduce their dry weight? There's a reason why.
Well, it could be a good idea, together with other considerations.
Yes, of course.
Okay. And now our second panelist, Professor Alberto Ortiz, is going to comment or ask questions.
Hi. Francesca, thank you very much, because this issue you can see in everyday life. And from clinical experience, I have some patients who are so happy that they were diagnosed of sleep apnea and got treatment because the quality of life improved. But I also have patients that they don't tolerate the CPAP, so they keep being unhappy.
Yeah.
In any case, if volume is an important determinant, then which day you perform the polysonography in a hemodialysis patient would be important. So are there any guidelines regarding this? The night of dialysis, the night before dialysis?
This is a very good point. There are no guidelines. But you see, I think that the best way, but this is my opinion because of the results we had with the studies we have already done, the best way to perform the assessment for sleep apnea is soon after the dialysis session, soon after, or the day after, in the midweek dialysis, non-dialysis day. Mm-hmm. This could be a good way to assess sleep apnea, because in that period, patients should be on their dry weight.
And did you observe any difference between these 2 days? I mean, the weight would be expected to progressively increase. So maybe there is a difference between the night of the day of dialysis and the night before.
There are studies about the sleep apnea and the dialysis session, and for instance, there is a very nice study, the frequent dialysis stay, where they assessed the sleep apnea with frequent dialysis, and with the also, I don't remember the name of that study, but it was also with the long dialysis, the overnight dialysis, and they have shown that they showed that the sleep apnea, the severity of sleep apnea decreased after the dialysis session. Okay. So it's very important. So this is important because it's another evidence that if we control volumes, the situation could improve, just controlling volumes. And I think that this is the reason why there is a wide range of the prevalence of sleep apnea in dialysis patients, because not always they are in their dry weight. Okay. So that could be an explanation.
That's a very important point, because I was looking briefly recent guidelines, for example, the KDIGO guideline for hypertension, and I couldn't find a mention of sleep apnea. I didn't find it also in the 2012 CKD guideline. However, in this year's European Society of Cardiology guideline for prevention of cardiovascular disease, it mentions screening for by question, as you said, do you know, screening by questioning patients with hypertension, patients with atrial fibrillation or at risk of atrial fibrillation, patients with heart failure for sleep apnea. So yeah, nephrologists, we are not so aware of the issue, it appears.
Yes, sometimes when I speak about sleep apnea, I have the feeling that the people think that it's just something that you like to do, or it's not really useful and helpful for patients. But this is absolutely wrong, because sleep, if you correct, we don't have trials, but there are so many observations that sleep apnea is related to risk of death and cardiovascular events, that I think we can't continue with clinical inertia. We have to screen patients for sleep apnea. And especially for renal transplant patients, because usually the renal transplant patients have nocturnal hypertension. They look, when they come to our office, they are maybe with normal blood pressure, but in the night they are hypertensive. And maybe this is why one of the reasons could be that that patient has sleep apnea.
Yes, indeed, the European Society of Cardiology guidelines, they mention that patients with nocturnal resistant hypertension, yes, they do improve with CPAP as long as it's at least 6 hours. However, yes, no mention of that in our KDIGO hypertension guidelines for patients with CKD.
Yes, I think that it could be a good idea for the European Renal Association to write something about that, because it's, I think it's important to underline this aspect of the problem, because it's a modifiable risk factor. I shown also that today there are devices for CPAP that are very small, I don't know if they work at the same level of those with more with the bigger devices, but we at least we should try, I think.
Does extended hemodialysis works better than conventional, or are there any studies about extended or nocturnal hemodialysis?
Olga, you are totally right, but we all know what is the situation of our dialysis wards, and we know how difficult it is to perform long dialysis, because it's not only a matter of giving the patients the opportunity to be dialyzed the overnight. It's important length of the dialysis session, and we know that it's almost impossible to have dialysis sessions which last 6, 7, 8 hours. It's almost at least in Italy, it's like that. It's impossible.
And I'm coming back to diagnosis because it's a problem. Polysomnography is the gold standard, but it's not available in everyday clinical setting. Do you trust questionnaires, Berlin questionnaires?
Olga, there are a lot of papers about sleep apnea with questionnaires, but honestly, I think that they're not useful at all. They can be a good start for a complete screening, but
screening.
They are
okay.
Very recently, I'm going to some meta-analysis about sleep in CKD patients, and there were tons of papers about sleep apnea, but the diagnosis was made by questionnaires, and I think they're not helpful.
I have a question. A question asks, is there any study in PD patients? Because most PD patients are almost always hypervolemic. What is your opinion? The question is about PD patients,
peritoneal dialysis. They have been very, very scantily studied, this kind of patients. But anyway, there is a study by Sidney Tang in Hong Kong, where, you know, they have 99% of patients on peritoneal dialysis. This was an old study by Sidney Tang, and the prevalence of sleep apnea in peritoneal dialysis patients seems to be lower than in hemodialysis patients. But there isn't a trial. This problem has been scantily investigated, very scantily.
Yeah, and I believe it's again a matter of volume status. If you don't compare patients volemic, you cannot screen for sleep apnea.
I remember that in this study, Sidney Tang performed the sleep apnea assessment before and after peritoneal dialysis, and he found that there was an improvement in the apnea hypopnea index, but just that. Nothing more.
Okay, I think we have to tie up because we are closing now. We are approaching our time. Any final comments from our panelists or from Professor Mallamaci? Do you have any final comments or any other question?
I think that my main message to our colleagues nephrologists is that we have to stop our inertia, because this is risk factor that we can in some way modify. So we have the moral, ethical commitment to do that.
I think that's the best comment to finish our discussion today on this topic. And let me add that CPAP is the gold standard therapy. So far, we have no randomized trial to prove any effects on high hard endpoints, but still it helps the quality of life of our patients, and that matters a lot.
Yes, yeah.
I hope you enjoyed this webinar. The next working group seminar titled Overweight, Obesity and Extreme Obesity Links with Renal Disease is scheduled on Tuesday, February 8. It's organized by the Obesity Working Group. On behalf of EuReCa-M Working Group, on behalf of our speaker and panelists, thank you for your attention. Have a nice evening.
Thank you.
Thank you.